So I'm Jacki Liddle. I'm an occupational therapist and research fellow at the University of Queensland. And I got into research a little bit by accident, in that I was working clinically and I encountered something that I thought I needed some help with. So this was working with people living with dementia, and they was just struggling with giving up driving. So went to the literature and had a look at what people were doing, and at the time people weren't really doing anything. And so I went back to the university and said, somebody should do something in this area, and they agreed, and they thought that that somebody should be me. And that's how I accidentally got involved in research. So I started down that path of really trying to understand what was so hard about stopping driving and what would help, because I think as OTs we're really practical. We want to understand better, but we want to understand in order to help. So that's how I got into research, and then I've just stayed because it's very interesting. I get to look at lots of different interesting, challenging things all the time. There's a lot we don't know, and there's a lot of things we could do better. And I think that that's what drives research. It's really practical and applied. And if you've worked with someone who's really struggling with something, it's hard not to be keen to do better and help them more. What has inspired my research work have been clinical difficulties. So hard problems, things that aren't easily solvable. I think if something's easily solvable, you know, you could focus on it for a couple of weeks and it would be sorted. But humans are not like that, and clinical issues are not like that. So being able to look at something that's so complex that you're not even quite sure of the first step is really motivating to me, because you get stuck in and you learn a lot, and I enjoy that. I'm not doing the same thing all the time. I'm looking at different things and I'm always learning. I think it's just what interested me. I think we can measure things at a symptom level, and we're pretty good at doing that. But I think everyone probably knows someone living with a lot of symptoms who are actually having a very high quality, great life, and people who perhaps don't have a lot of symptoms who are really struggling. So I was more interested in that broad, what makes a good life for people, and it's highly individual. So we needed to find better ways of investigating it and measuring it and figuring out for each person what makes a good life. We need to use ways of measuring outcomes and talking to people to really understand for that person what makes a good life. Sometimes it's about control and choice. Always it's about doing, going to the places that are important, accessing the people who are important to you. But also I think there's a big element of managing changes in a way that you can find a new stability and a new way that to live that's meaningful. And that's not always easy for people, but people are actually great at figuring out how to do it themselves, and we can learn from them in order to help other people as well. One of the areas I researched was looking at deep brain stimulation for people living with Parkinson's disease. And there is lots of call for measuring outcomes, but those outcomes have generally been at the symptom level, and hadn't picked up on the complexity of even having a really positive change to your symptoms and how that can impact on somebody's life and relationships and so forth. In developing my research questions, I'm really looking at what matters to people, and also how can we frame it in a way that's useful. So I think, like most people, I'm really curious and want to understand things just to understand things, but I think we need to actually say, if we're going to ask people to share parts of their lives with us, it has to be for some purpose. It has to lead to helping, improving outcomes and things like that. So when I'm framing up my research questions, I'm looking at what do we want to know, or what do we need to know in order to change practice or change the system and do better. I have had that occupational focus to my research, partly because I had really good mentors. I was fortunate enough to have Chris McKenna as my PhD supervisor and through university, and that was emphasised as such an important lacking area in a lot of outcome kind of research. But also since my PhD and postdoc, I've worked in teams where I'm usually the only OT in a research team. And when you're not hearing much happening in the occupational area, it makes you want to emphasise it and convert other people to look at those aspects, because people get stuck on other things that I think are a bit less important. I would advise occupational therapists wanting to get involved in research to find a question, a burning question related to their practice or related to their life experience, and start there, because I think it's better than starting with a gap in the research or something that you've kind of heard a little bit about. If we have a buy-in, if we really want to know for a purpose, I think we do better with our research. I've researched a lot of different things, so there's been a range of outcomes. And so, for example, when I was looking at why did people find it so difficult to stop driving, this led to the development of a program to support people who have interruptions to their driving, which is called Car Free Me, and it's available as a training program. I've worked with engineers and other technology-based teams to develop technology-based outcome measures. So, for example, we're using geolocation data to measure life space, which is that area in which somebody conducts their activity, so we can monitor if we intervene to help someone access the community, does that make a difference to their life space? Are they getting out of their home a bit more? Are they doing things in the community? And then we can look at some other aspects like quality of life and how they feel about that. Research has influenced my practice in that I'm probably a clinical researcher rather than a clinician these days. I have a lot of time for people trying to do creative things and then finding a way in which we can build the evidence around that. I think sometimes we can get a little bit paralysed by the thought of there must be a big systematic review before I'm allowed to do anything to help this person. And the reality is a lot of the groups I've worked with, there hasn't been that background, but we have good core practice and we should start there and then build the evidence from there. If occupational therapists want to get involved in research, they should just make contact with a researcher. There's often researchers who are looking for clinical populations or clinical situations and they'd like to collaborate. I don't think I know of any researcher that wouldn't be keen to hear from a clinician with a burning question or an idea. And it doesn't have to be difficult. It doesn't have to have all the methodology words that you're terrified of. It can be a really practical question that you work on together. I've been involved in multidisciplinary research because I think that that's how I like to practice, and then partly for practical reasons. So the research I'm involved in right now is a co-design of technology with people living with dementia, and that research is based in an engineering department. I'm not going to be able to develop I'm not going to be able to develop technology on my own. We need the whole team to do that. I see occupational therapy as a really core part of that team, but not the only part. I think occupational therapists are a really key part of any research team and progressing research in that we're very practical. We have a holistic focus. I would like to say to occupational therapists thinking about doing research to do it, to make contact with researchers. They don't always have to be in the occupational therapy department. The research doesn't always have to be a trial or taking place in a hospital, but find that burning question and then find someone you think you could work with and make contact with them. And I think it would make our evidence base a lot stronger. It's always hard to know what changes for people as a result of your research. I love coming to conferences because that's when I hear from clinicians who've applied things that I've shared. So I have had really nice experiences of people saying that life space that you showed us as an outcome measure, we're using that. I've introduced it to 3 different hospitals and we're using that to think about people's outcomes. And we're running a trial now for supporting people living with dementia who are giving up driving, and we're just starting to get some of that feedback about how life-changing it is to get support for something that's so devastating and so difficult. And I love hearing that kind of thing. It makes it much more motivating to write papers. There are lots of ways of getting involved that don't involve running a big project on your own. That there are lots of projects where you could be a participant, or you could, maybe help with recruiting participants, or papers, you could be involved with writing to give that clinical perspective. So it's just about being open to it and making contact with someone and not being scared that it's going to be all statistics or tricky jargon, because it is actually about learning something new, and I think we all like to do that.